Kulkarni will be speaking on regionals in coronary stented for emergency surgery.
Good evening, friends. Chairperson Dr. Bala Venkat. I'm going to talk about regionals in coronary stented patients for emergency surgery. I'll just give a couple of case scenarios. Case 1, a male 76. I think you might find these cases almost similar scenarios in your day-to-day practice, especially people working in big institutes. Hypertension, diabetic since 20 years, OHS, insulin since last 2 years, smoking for many years, ischemic heart disease, 10 to LED 6 months back, dual antiplatelet therapy, fall at 3 p.m., usually takes his antiplatelet medications at 1 p.m. after lunch, has a fall at 3 p.m., comes to the hospital by 5 p.m., does a workup, has a fracture radius ulna, routine workup including a cardiology consultation is done, and next day morning comes up for the theatre. Second case, female 72, hypertension which is controlled, diabetic since 20 years on insulin more than 6 years, ischemic heart disease and anti-anginal medications following angiography, which has shown over 40 to 50% right coronary osteostenosis. Serial creatinine chronically raised around 3.5 but stable. History of congestive cardiac failure about 6 weeks ago following an air travel. Ejection fraction has dropped from 45 to about 30%. Repeat angiography after stabilization of this failure shows osteostenosis now about 80%. PTCA is done, single stent to osteo, monumental procedure, develops a pseudoaneurysm at the femoral arterial puncture site. Conservative management, they try to do pressure and try to block the pseudoaneurysm. Day 5, it fails, and day 5 is for evacuation of the clot and repair of the pseudoaneurysm. So these are the two typical case scenarios which I have discussed basically, or we'll discuss where the apt to the topic. Sorry. The issues are about altered coagulation. Though these patients are on antiplatelet medications which they have not been stopped, those are both are emergency or urgent. I wouldn't call them emergency surgeries; they are more of urgent surgeries. Some of the issues which are going to be there in these patients are: one, whether are you going to do general anesthesia or regional anesthesia? Altered coagulation and regional guidelines, what does this say? Can we give some platelet transfusions preoperatively? About neuroaxial blocks, peripheral blocks, and what the AAG by guidelines say. Where's Dr. Murli? Yeah, he said about the wife and the girlfriend, yeah? Which is better? Surprise, surprise. General perception, the regionals are safer and better as far as the morbidity, mortality, reduction in the thromboembolism risk. That's what we were trained for, or that's what when we trained we were told. However, large studies and meta-analysis have failed to confirm improved results. Well-controlled trials of women, they have failed to improve results and safety. However, regional anesthesia patients have much better pain control. It does facilitates rehabilitation, and obviously in our settings, and I think all over the world, where the issues are about cost constraints, and especially in our setups where infrastructure issues or the backups and about the cardiology, about the critical care and all this is, and especially for high-risk patients, I think regionals will definitely have an upper hand as far as your safety and overall cost constraints are concerned. There's no doubt about that regional anesthesia is gaining popularity. At the same time, anticoagulant medications are also better, powerful, and they are even increasingly used as well, both for therapeutic as well as for prophylactic purposes. As far as your patients on anticoagulations are concerned, there are a lot of guidelines provided by the American Society of Regional Anesthesia. Most of the national societies have guidelines about Israel, all the national societies. These guidelines do not have any hard data or prospective control trials because of a lot of logistics issue, because there are not, the complication rates are much lower overall. So to actually get a hard data to actually give some guidelines will be very difficult. These are all based on case reports, case series, expert opinion, and the known knowledge about the pharmacology of these medications which are used as anticoagulant or for prophylaxis or therapeutic purposes. Most of these guidelines are mainly for neuroaxial blocks, and the principles of what the guidelines suggest to do are applied to peripheral D blocks or peripheral blocks as well. They do not guarantee or assure a specific outcome. There is no guidelines about the combination of drugs. If somebody has got low molecular weight heparin started, what happens if you started diclofenac or your non-steroidal agents. Newer drugs, there is very little experience, and most important at the end of these guidelines, what they said is it This allows variations based on clinical judgment and experience from case to case basis. what you need to look at as the risk-benefit ratio. That is what these guidelines say, and then take an informed decision. As far as the platelet transfusion, there is a suggestion that you can give perioperative platelet transfusions to patients who are on dual antiplatelet therapy, where if you feel that regional anesthesia is considered safer in that situation than general anesthesia. There were a lot of, Doyle and suggested some data that you should, if at all, if you need to give platelets, you should give after 3 half-lives of clopidogrel. That clopidogrel half-life is 4 hours, so it's about 12 hours. After the last dose, the whole logic being that the blood levels of clopidogrel might be very low, so that it would be probably safer and the transfused platelets may not get deactivated by circulating clopidogrel. However, there is some suggestion that donor platelets might get activated to a greater extent than endogenous platelets by the thrombogenic stem surface. Adequate levels of clopidogrel may not suppress the transfused platelets. Again, it's very difficult to know the platelet count and does not reflect adequate function, and there is no reliable or accurate test which you can assess the platelet functions. So overall, if you give transfused platelets, it could be possible that you might increase the risk of stent thrombosis, myocardial infarction and death. And most important, transfusions are not without risk as well. So in a way, it is not justified to give platelets preoperative in patients just because to put in a block or put in a regional anesthesia. However, this platelet transfusion may be restricted to control of life-threatening bleeds. About regional anesthesia neuroaxial blocks, what you are worried about is this dreaded complication about spinal hematoma. Let's see something about the spinal hematoma, which is defined as symptomatic bleed in the along the neuroaxis, sufficient for neurological dysfunction. The actual incidence of neurological dysfunction following central neural blocks is unknown. Most of these cases are unreported, and what we get is basically whatever reported cases only. Most of them are they are not prospective studies. They are retrospective analysis of whatever data is available, and it's very difficult to do prospective studies because of a very low rate of complications. However, there are a lot of reports about what people have done retrospective studies. Vandermeulen has studied 61 cases spinal hematoma from 1906 to 1994, and basically what this says, 87% at hemostatic abnormality of hepatic needle pressure. The commonest cause for spinal hematomas is idiopathic. It comes much more commonly without any anticoagulants. Second cause is if anticoagulants are given to the patient and some procedures like a knee replacement is done. And the third is some vascular malformation is there in the spinal cord which ruptures and then causes spinal hematoma. In these cases, most important Vandermeulen, one of the observation is that he said was spinal cord ischemia or neurological dysfunction seems to be irreversible. Patients who did not have laminectomy within 8 hours of onset. Moyer also studied about 33 spinal hematomas, about 2 million neuroaxial blocks, and what he suggested that the risk associated with epidural analgesia in women undergoing childbirth was significantly less, almost 1 in 200,000, compared to elderly women undergoing hip arthroplasty. The rate is almost about 1 in 3,600. That is with a catheter. Yeah, single shot epidural is probably 1 in 6,000. That's what he said about the incidence of spinal hematomas. And he also said that women undergoing hip surgery under spinal anesthesia had an increased risk of spinal compared to all patients undergoing spinal anesthesia. All patients spinal anesthesia almost 1 in 480,000. A woman undergoing hip surgery under spinal almost in 1 in 24,000. That's what he said. This is about spinal. So what he suggested is that the risk of bleeding increases with age, female gender, associated abnormalities of spinal cord, which makes the performance of the blocks can be difficult. You might have to have multiple attempts, and presence of underlying coagulopathy, difficult knee replacement, indwelling catheter during sustained anticoagulation is one of the risk factors for this thing. However, also noted there are lack of clear guidelines for this, and most important, catheter removal carries the same risk as insertion. The incidence from the various retrospective analysis studies what we have is spinal 1 in 220,000, epidural 1 in 150,000. However, if a single anticoagulant like a low molecular weight is given to the patient, the risk increases many folds, and for spinal is about 1 in 40,000, epidural 1 in 6,600 single shot, and if you use the catheter, you are 1 in 3,000. Most important, you should be aware of the symptoms of spinal cord hematomas. It might be low back pain radiating to the legs. It might be motor or sensory symptoms, bladder bowel symptoms, or a radiating pain or segmental radicular pain. And if somebody already has an epidural on board and if it's working, then obviously a prolongation of the block or recurrence of the block after reversal, you should be very careful. One study which showed basically that when low molecule is given post-operatively with a patient with an epidural catheter after removal of the catheter, the incidence or the timing of hematoma almost from 15 hours to 3 days. Most of these patients were elderly. The implications for us is that because a lot of times if at all in high risk patients, if we remove the catheter, we might follow them up for 24 hours afterwards that they are moving with the limbs and everything, but it can be up to 3 days. So sometimes in a very high risk patient you might have to look after or at least make sure that the patient is okay up to 3 days. The source of bleeding is again a controversy, whether it's an arterial venous. So many times when the laminectomy was done, the amount of blood which was seen was much lower than what we routinely inject for having a poor epidural blood patch. So in one report, only 4 ml blood could be evacuated after doing a laminectomy, and still the patient was very symptomatic. So most important was spinal injury, there should be a high index of suspicion, especially in the high risk group. We have seen the high risk factors, which in those cases which are the incidence is higher. Regular assessment and documentation. Numbness, you should, as far as analgesia goes, very low concentration of local anesthetic so that you do not get a totally numb patient. You are low red flags, the symptoms, if the recurrence of the blocks, you need to be very careful, or if the block prolongs, or if it's partial, then you need to be very careful. And most important, prompt intervention in case of a problem, any neurological dysfunction, as far as the MRI, a consultation and early intervention, because it's well documented that if you intervene early, outcomes are better. And again, documentation and follow-up is equally important. Peripheral blocks, again undefined risk. Nobody knows about because we do not have enough data to recommend, that's what the ASRA guideline says, but most of the experts feel that for neuroaxial, the guidelines which are applied for neuroaxial blocks may be applied for deep peripheral blocks. These are based on anecdotal case reports, and most of these cases, what the problem was bleeding into the deep spaces. That is what they were worried about, and they were all with therapeutic anticoagulation rather than prophylaxis. So the actual risks, if at all, if you use any of the medications for thromboprophylaxis, is actually not known. And as I said, the most important problem, risk of bleeding, it might be real or perceived. Main difference between spinal hematoma and peripheral nerve plexus block is the fixed and the non-compressible space in the spinal canal, where in the periphery it might be, you have a lot of space for the blood to accumulate, and bleeding is a more of an issue rather than a neurological dysfunction. So during the cardiac procedures, it is well documented that no neurological complication was a result of vascular injury. The largest study by Shelley and all, where they started warfarin in the post-operatively for prophylaxis, and they have continued lumbar plexus catheters and removed with an INR as high as 3, which was, they didn't know about it when they removed it, but they didn't seem to have any problems with it. And basically many reported cases of significant bleeding have been reported where there has been coagulation abnormality, and in all patients neurological deficit recovery was complete within 6 to 12 months, suggesting that significant blood loss rather than neurological injury was a complication. Now, with all these complications or complicated guidelines which doesn't tell you anything exactly what to do, the Association of Anesthetists of Great Britain and Ireland came out with a guidance document in 2011, which is available on the net, to basically give some simple guidelines what we should do. And what it says basically that there is no such thing as no risk. Risk is going to be either minimal risk or high risk. So what they say is that they have just classified all the procedures what we do normally from normal risk to very high risk. They have not defined what do you mean by high risk or what do you mean by normal risk, but whatever your data available, the things, and there is a local infiltration, superficial blocks, facial blocks, superficial perivascular deep blocks, paravertebral, spinal, epidural, single shot spinal and epidural with catheter. And they have given what sort of procedures which they, when they talk about epidural, paravertebral, deep block, which sort of procedures which they are looking at, whether local infiltration. And they also basically very clearly say there is no clear data, there are complexity in the guidelines, abnormal coagulation is a relative contraindication at times, but however at times the alternative like a general anesthesia might be even higher risk. Then decision should be taken whether on a very balanced whether regional anesthesia is better than general anesthesia. And there is also some suggestion about senior and an experienced anesthetist. There is no hard data prove that an experienced or a senior anesthetist does it would be outcomes would be better or there will be less complications. However, the number of attempts which is directly related to the complication rate or the hematoma rates, which will probably less with an experienced, and ultrasound probably will reduce the amount of, that does reduce the amount of vascular punctures, which is well documented. So based on current information and understanding, the decision should be made case to case with consideration for potential complications, and the risk benefit ratio should be these things, and one should be able to justify the decision. Now in today's litigious environment, it is difficult to take sometimes a decision, but however if you do not take a call and if you do not take a balanced decision, sometimes you might do more harm to the patient than good. So you need to take a very balanced approach. In both the patients which I said, the first patient was done under a brachial plexus block and axillary, and the second patient I gave a single shot spinal. Both had an uneventful recovery and a post-operative period. Thank you.
That was excellent, sir, and finished in time. And your calculations are always right, and we are very happy that you are the treasurer of AORA.
Now we have